Good morning, everyone.
Good morning.
6.
Good morning. David, can you hear me?
Yes, I can.
Okay, I'm driving almost to my office, but I may be quiet for the first 10 minutes or so.
Okay, no worries. Thanks for joining.
Good morning. This is Brittany Collins Jefferson. I'm actually off camera again. I'm dropping off my children. And once I get in my office, I'll be back on camera.
All right, thank you, Brittany. All right, good morning. Thank you for joining us for today's Advisory Committee for Resilient Nevada. It is 9 a.m. on June 8th, and we are ready to start our meeting. Call this meeting to order, and Joan, can you take roll, please?
Jessica Barlow. Brittany Collins Jefferson.
Present.
Lenitra Grady.
Good morning, present.
Ryan Gustafson.
Good morning, present.
Dr. Kamyar.
Present.
Carissa Loper. Carissa Loper. Will you
She's here.
unmute and then
Present.
Thanks.
Present.
Thanks.
Thank you.
Catherine Loudon. Cecilia Maria.
Present.
Elise Monroy. Darcy Patterson.
Present.
Pauline Sala is excused. David Sanchez.
Present.
Ariana Saunders. Ariana. There she is. Okay. Cornelia Sheehan.
Present.
Laura Sherwood.
Present.
Dr. Carla Wagner.
Here.
Quintella Winbush. Okay, you do have quorum.
Thank you, Joan. We will move to agenda item number 2, which is public comment number 1. At this time, if there's anybody available or interested in public comment will be taken, and we ask that please avoid repetition and limit your comments to no more than 3 minutes. Do we have anybody interested and available for public comment? It looks like I have one, Joan. I have Katri Saunders.
Hi,
Katri,
hello everyone. How's everyone doing today?
good morning.
So glad to be here. I was just making sure I had the correct information to send over documents for my recommendations. And 2, I was wondering, is at any time, is there going to be a notice of funding for the public for people that were affected by the opioid epidemic? for different resources for community members, not just for different programs that are being allocated. Thank you.
Thanks, Katri. If you could email Don Yohey your question and anything else that you'd like to add in there, she can email you back with a response to your public comment. And Don will put her, wait, can you put your? No,
I don't see a chat box down here this
there's
time.
actually not a chat box. Do you have her email?
I don't believe it's listed in any of my previous emails. So if you would like to give that to me, I can jot that down real quick.
Yeah, Don Yohey for the record, d.yohey, Y-O-H-E-Y, @dhhs.mv.gov.
Okay, perfect. Thank you so much.
You're welcome.
Thank you, Katri.
You're welcome, you
Do you
guys.
have-
Have a good day.
Thank you. Do we have anybody else for public comment number 1? I do not see anybody else. It looks like we may have gotten one more of our committee members here. I'd like the record to show that Catherine Loudon is present. Catherine, thank you for joining. We will move from public comment number 1 to agenda item number 3, which is for possible action approval of the minutes from May 18th. At our last meeting, we had a review or a reminder by Dawn of the ACRN's purpose and responsibilities, and we reviewed the results of the survey that the committee members completed. We also talked about how we would determine to go through the recommendations and voted to approve some recommendations for prioritization by Mercer. Do I have a motion to approve the minutes from our last meeting?
I'll motion to approve.
Thank you,
This is
Carissa.
Carissa Loper for the
I'll
record.
second.
And who was that on the second?
Brittany Collins.
Thank you, Brittany. We'll now take a vote to approve the minutes from our last meeting. All in favor, please say aye.
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 All, Dr. Wagner, did you have a question or is that an aye? Thank you. All opposed, please say nay. And do we have any abstentions? The minutes from our last meeting on May 18th have been approved by the committee. And we will move to agenda item number 4. Agenda item number 4 is also for possible action. We will be given a presentation and we will have a discussion about the Mercer objective tool and the rating of the ACRN recommendations, as well as the public recommendations and the recommendations that Mercer has put together for us through our conversations and meetings throughout our time together. I'd just like to have the record note that Jessica Barlow is now present. Jessica, you are here, correct?
Yes, thank you so much. I'm having a really bad signal because I am working from home today. So everybody please excuse my tardiness. I apologize.
It gets pretty common now that we're going to have these technical difficulties while we're working from home. Thank you for being here today.
Thank you.
All right, so at this point, I would like to, I think we're giving it to Courtney or Dr. Cantrell. Sorry.
Yeah, did you have an intro you wanted to do for us
Yes.
before I get started? Awesome. I'm going to do my screen share while you're doing that, if that's okay.
Yes, thank you so much. So the priorities per Senate Bill 390 are to include priorities related to the prevention of overdoses, addressing disparities in access to healthcare, and the prevention of substance use among youth. Per the One Nevada Agreement, approved purposes for the fund means uses to remediate the harms, impacts, and risks caused by the opioid epidemic. And these are consistent with SB 390 or listed as an approved use for abatement purposes in any plan approved by a bankruptcy court. Mercer will explain how they use their objective tool to prioritize recommendations and share where the ACRN's recommendations fit into their assessment. The Department of Health and Human Services received individual members' recommendations, which were reviewed to see if and where they fit into Mercer's, and then they were prioritized. If you feel your recommendations are missing or you feel strongly about one, please let us know. At this time, I would like to ask Dr. Cantrell to take the floor.
Hi, thank you so much, Chair. This is Dr. Courtney Cantrell. Yeah, can I just verify, because two screens and Zoom don't always get along. Are you guys seeing a full screen view of the PowerPoint?
Yes, ma'am, we are.
Okay, excellent, excellent. So I am here today to talk through the recommendations of the scoring methodology that we developed for Nevada specifically, as well as to show you the tool that I think you might already have access to that is 90 or so recommendations with all of these ratings applied to those recommendations. So first I wanted to see is Dr. Woodard on yet? She was rushing.
I don't believe so. Let me double check.
Okay, so I'm going to kind of tee it up a little bit to say that part of the requirement in legislation was to come up with an objective scoring criteria for the recommendations. Because with so many different priorities and everybody's in different areas and has different needs, they wanted to come up with a way of more objectively scoring them to see the things that are going to impact the most people, that are going to hit the legislative priorities, that are going to be not too impossible to implement, and things that are kind of well within the scope of what's available for the funds that are coming out. So we did work to develop specifically for Nevada a scoring methodology for the recommendations. We'll talk about recommendations in a second, but here's what the scoring process was like. We scored each of the recommendations based on their impact, urgency, feasibility, and then finally the legislative target, whether or not it hit one of those three legislative targets. So I'll go through each individually. First is the impact. We scored impact on a Likert scale of 1 to 5. So we looked at the number of lives that were affected by the recommendation, the magnitude of impact on individuals, and the impact to health equity on that recommendation as well. So I'm going to go ahead and show you guys what our actual scoring tool that is in the report looks like. I think there we go. This is just kind of a taste to give you a better idea of what it means when I'm talking. Sorry, my mouse is jumping all over the place today for some reason. Okay. So as I just mentioned, impact was the first thing we scored. First, we looked at the number of lives that would benefit or be impacted by each recommendation. We scored it from 1, which would be low, meaning low priority, meaning very few people would be impacted, all the way up to high, which would be a 5. So again, low is it impacts a small proportion of the population of Nevada residents. And then high would be impacts almost all the entire population with almost no exclusions. So in truth, there were very few that hit on the high, except, large multi-stigma campaigns would hit that 5 on that rating. So we rated it on the number of lives benefited, and we separately looked at the magnitude of individual impact. So for each individual that recommendation impacts, does it save a life? In that case, it's going to be rated really high, like a 5. Or is it something that maybe slightly improves treatment quality or might be somewhat of an increase in well-being for people? That would be rated a little bit lower towards a 1. And then there's a whole world in between of those two ratings that we could use. Very few things were a 1, I will tell you that, because most of the things that need to be done are meaningful to people's lives. That goes beyond just the minimum well-being. And then for impact, we also looked at the relative impact which that recommendation impacts health equity. So the lowest rating would be recommendations that would be detrimental to health equity or result in disparities, even if it's unintentional. I don't think we rated any low. We didn't find anything was just explicitly going to cause harm in that way. But then at a 5 would be recommendations that are actually focused on alleviating disparities and promoting equity. Those would be ones that really target underserved groups with the intent of equalizing that benefit from healthcare and really optimizing it for those individuals that have been left out of the system in the past. So those 3 scales were actually taken and averaged together in order to get the impact score. Similar thing happened with urgency. We looked at only 2 factors for urgency. First is the availability of alternatives. So are there currently other things that are filling this gap within Nevada? That would make the urgency go down a little bit. Are there risks or consequences of a delay in implementation? So will people die if we don't get this done? You know, if naloxone weren't in effect in Nevada, and that would be a very high risk or consequence of delay, is not having naloxone versus, you know, some other things that if they don't get it implemented right away, will people die? No, but people will suffer, or well-being will be a little bit lower. So those will go a little lower down on the urgency scale. So those 2 things were averaged together to get an urgency score. Third, we have feasibility. So how easy is it to implement? This is where you kind of want to pick the low-hanging fruit sometimes, because you can get more bang for your buck on those. So we rated those based on the current infrastructure available. So is it already something that's in the system? Does a recommendation just require expanding something just by expanding a service or expanding a payment for it? Or is it creating a rehab facility with beds and a location? So a building would have to be built, those kinds of things. That would be very very infrastructure dependent. So it would actually go low on feasibility if it requires a lot of infrastructure to be built. Ease of implementation or effort. Some things are really easy to implement. Just write the check for it and pick which one you want and go with it. Other things are a lot harder. They might have some political barriers to getting done. Things might take a lot of regulatory changes in the system to happen. So we rated those as a little bit harder than things that, again, were already in the system and you're just talking about expanding it or adding some more slots to a service. And then finally, for feasibility, we looked at the availability for implementation. So not only staff and community, but also the relative financial resources that are or aren't available. So when it comes to financial resources in particular, we didn't estimate how much these recommendations would cost to implement. In a lot of cases, the recommendations are pretty broad, so we don't know what the cost might be, but you can get a general idea. So inpatient beds tend to be not only expensive on a one-time cost, but they also need some sustainability funding too for all people that are going to use them. So those would be a little lower on feasibility, whereas doing a big education campaign, a one-time campaign, would be a little bit higher on feasibility because it's a one-time cost. You don't have to worry about the sustainability, billboards, TVs, all that. Social media is already there. So it's a matter of just implementing it. So we took those 3 scores and you can add those up for a total. Now, in addition to those, we also looked at which were legislative targets and which weren't. So those legislative targets mentioned in Senate Bill 390 are overdose prevention, addressing disparities in access to healthcare, and the prevention of substance use among youth. So if it seemed to fit one of those categories, then it got an extra 3 points added to the total of the ones above it. So the recommendations in the file can be sorted by those different, by impact, by urgency, by feasibility, as well as by the legislative target score. The total priority scores that are calculated across all of those range from 3 to 18. So 18 is the highest. Actually, I think now the possibility was 3 to 18. I think the actual scores ended up being between 4 and 14, somewhere in there, or maybe 7 and 14. Blanked right now. And then the recommendations are categorized by allowable expenditures and categories in legislation. So let me go ahead and show you guys then what the outcome looked like in terms of an Excel file. And you're not going to be able to see the whole thing. I believe you have a copy of it, but it is awfully big. So you guys can see an Excel file on the screen right now, right?
Yes.
Thank you. Okay. So down the left-hand side, the numbers, you don't have to worry about. That's kind of our internal numbering so that we can put them back in the order we had them in the first place. So the second column is all of the recommendations. Mercer came up and developed these recommendations. We brainstormed some, through with our expertise, and a lot of them though came from the documents we reviewed to develop the needs assessment. So there were over 70 Nevada-based documents, and a lot of those reports had recommendations in them. So we put those in here. Sometimes we combined some together, sometimes we had to split them apart so that they were all at about the same level. The recommendations, the ACRN's recommendations were very broad, the ones that you guys had sent us the first time, and I'll show you those in a minute, but they were very broad, kind of a 100,000-foot view that a lot of programs could fit inside of. There's also the possibility of doing very, very, very specific recommendations. So like implement this program in this region. So what we tried to do is give you guys the most flexibility we could in developing these by hitting somewhere in the middle. So our recommendations are meant to be specific enough that they target populations and activities, but not so specific that you don't have the freedom to determine what program might meet that recommendation's goals, or that you might be able to tailor regionally depending on which aspect of that recommendation can be or needs to be implemented in different areas. So we tried to hit that middle ground of the recommendations. So they're all listed here. There are about 90 of them. We have a little notes section. There is a column D is called gaps, and let me actually increase it even more. The gap section is just indicating where in our needs assessment this recommendation seems to fall. So if this gap was found, I think the first one is the education on the safe use and storage of opioids. Well, that was a gap that was identified in our primary prevention section. So we put primary prevention there. That kind of helps us to track back to the needs assessment report. Column E is legislative. So these are in Senate Bill 390, there were, I believe it's 14 categories, legislative categories. Yeah, there are 14 that Johns Hopkins actually recommended in the use of these funds for different states. So these are the ones that you guys have already been using and that you were conceptualizing your recommendations around. So what we did is we looked to see which it seemed to fit most. A lot of these recommendations could of course fit more than one category easily, but we just kind of picked one to make sure that it does actually fit into one of the categories. Next, you will see this first little strip, columns F, G, and H. Those are impact scores. As I mentioned earlier, a number of lives, the magnitude of the effect on each life, and health equity are three things that were looked at to get the average score for impact. So those three are averaged out, and you see in column I, that's our average impact score. Same thing for urgency. You have the two subscores that are averaged to give you an average urgency score. I'm going to scoot over a bit more. And then for feasibility, we have infrastructure, ease of effort, and resources available that all come together to average into that feasibility score. So the impact, urgency, and feasibility averages were totaled together to give you your rating total, but what was added to that was that legislative target. If you'll remember, overdose prevention disparities and substance prevention of substances among youth were the three things that if you hit one of those, you get an extra 3 points. That recommendation gets an extra 3 points. So impact, urgency, feasibility, plus whether or not it's a legislative target is what resulted in the rating total. So what you see here, and I'm going to make it a little bit bigger even if I can, is the most important column is R, which is your rating total. And what I've done is I sorted the whole file first for the legislative target. So first I wanted to see all those things that do meet one of those legislative priorities. And second, I have then taken and ranked them according to which had the most points or the highest score, all the way down to the lowest. And I think among the legislative priorities, the lowest score was a 9.2. Like I said, I think the lowest for the whole file was somewhere around a 7. So, Yeah, so as he mentioned, if as you guys look through the recommendations, and I believe you already have a list of those as part of your meeting materials, if there are extra things that you think didn't make it in here, we definitely want to hear about those. I also want to mention that at the bottom of this file, we received your recommendations, and what we did is we looked at your recommendation and then looked at kind of where it fit within the recommendations that we made. So the first one about expanding access to evidence-based practices, that's actually one of the legislative categories that we mentioned, one of those Johns Hopkins recommendations. Since it's so broad and includes so many things from early intervention to treatment to recovery support, that is incredibly difficult to rate because it's not specific enough to have an idea of what kind of resources would be made or what changes would be made into the system. So what we did over on the right-hand side, this third column, is our response to where we think that recommendation is accounted for above in the recommendations that we came up with. So for instance, create interventions at a family level to fortify youth, transition age youth, and young individuals' sense of security and prevention. We didn't have that originally in ours. So where it says included, that means that we went ahead and included it because it wasn't there before. Some of the others, services to reduce the harm caused by substance use. Again, we put C, harm reduction, because if you filter by this column E, legislative gap, legislative column, they choose harm reduction and everything falls under that category. So there were quite a few that were so broad that we imagine that you can probably look under that category and then see a bunch of things that fulfill that requirement. And I think that was the main kind of introduction to the tool. Are there any? I'm sure there are. Are there any questions? Or Dr. Woodard, actually, did you want to say something more about how they can use this tool?
I believe she's here. Let's just give her a moment and see if she's maybe on another call or trying to work out technical difficulties. Thank you so much for that, Dr. Cantrell. What seemed to be super confusing and there were some big gaps in understanding was totally clarified right there, and this document is looking really good. Thank you for all that hard work. Dr. Woodard, are you available for comment?
I am. Sorry, I'm having internet issues. I don't even know. Can someone give me a thumbs up if you can actually hear me?
Mm-hmm.
Okay. All right, great. So I apologize I wasn't on for the very beginning, but wanted to just provide a little bit of context, because believe it or not, this group has actually covered quite a bit of ground over a short period of time. So just to sort of frame where we have been and where we are going. So Mercer has conducted the needs assessment, and through the needs assessment had identified gaps. From those gaps,
Oh, we lost you, Dr. Woodard. We still have no audio from you.
I may pop in a little bit then, if that's okay.
Please.
So from those gaps, we brainstormed and came up with recommendations. Again, not just brainstorming, but also they came from the needs assessment documents that we read in advance. They also came from from listening to you guys with the additional gaps. I will say that there are probably things we missed because we're not on the ground in Nevada, right? We're going with what we saw in the information we had. There were even probably gaps we didn't realize we didn't see because the documents don't necessarily say there's a gap. So sometimes that can be a little harder. But we've rated these in a way that's objective, and that was one of the SB 390 requirements, was to have a good objective measure of prioritization. So I believe what Dr. Woodard was going to say next is the way that you can use this tool is to sort and look at that last column of ratings to see what really comes to the top. That's a tool to help you to decide which priorities you want to put in your report. And Don, let me know if I'm wrong on this, but when you're creating your priorities, you don't necessarily have to use the ones in this tool. You don't have to cut and paste the top 10 and move those into your report, but the tool should be used to inform your report going forward as far as the things that you think are the highest priorities with some objective measure information.
Yes,
Don, did you?
that does make good sense, Dr. Cantrell. Thank you. And I think that Dr. Woodard is back in. We're going to transfer presenter to her and see if we can get her with some stronger internet connection. And then Dr. Wagner has a question. Let me see where Dr. Woodard is almost in. There we go. Give me 1 second, Dr. Wagner, and let me have Dr. Woodard take the floor, and then I will call you as soon as it's available. Dr. Woodard.
Thank you, Chair Stephanie Woodard, for the record. I just want to apologize and appreciate your patience and with me and my connectivity this morning. So I'm not really sure where I left off, so I'm going to just start back from the beginning. Needs assessments, identified gaps. From those gaps, both the ACRN and Mercer, but also governmental agencies have made recommendations on how to most address those gaps. I believe Dr. Cantrell has probably already mentioned that just because it's a gap doesn't mean that it doesn't exist in totality, but that as it is a gap, it's been recognized that there is still need for more. So where you see some of the recommendations, it's not to say that some of those things aren't occurring, but that they're just not occurring to scale. So now that we have the recommendations, and certainly we've spent some time with the ACRN to develop the recommendations specifically from this group, we thought it would be best to really bring forward all of the recommendations that are available to date for the ACRN to contemplate in determining which recommendations, all or some, the ACRN would like to move forward as their recommendations. In addition, there may still be some recommendations that you as a group would like to make that are not here. So what we're going to need to do is identify what those recommendations are, so that we can very quickly move some of those forward. So I had already identified that there's one that is not on the recommendations that we will want to make sure that we have included in our overall report. Not necessarily, it doesn't have to go into the ACRN report, but I do know that it is something that we will want to have ranked so that it can be contemplated for the state plan. And that is an overdose fatality review committee. It has been the topic of many discussions and is a critical part of what we believe is needed for surveillance and really just having a pulse on what is happening in the communities as the overdose crisis is really rapidly evolving. So it will help really drive a lot of our recommended interventions. So Chair, I'm going to turn it back over to you because I know I had seen some hands go up and I anticipate there's some discussion.
Thank you, Dr. Woodard. I do have Dr. Wagner with her hand up and a question or comment. Dr. Wagner.
Hi, thank you, Carla Wagner. I just have a question about the scoring process.
Dr. Wagner, real quick, you're a little bit low on the audio, just a tiny bit, but almost there.
How's that?
Good enough.
Like,
one.
I don't really have
Sorry.
a lot of options here, but okay, let me see. Hold on.
It's workable. It's workable.
Better?
I just wanted
Okay.
to put that out there. Okay.
All right. I have a question about the scoring. Who did the scoring? What's the background of those folks? What's their connection to sort of on the ground work? Where do they come from? Just because I can imagine, we're talking about this as an objective tool, but like I just want to know about how that got done.
Right. Anything life sciences, you're going to have some subjectivity to it, right? Yes. So what we did is I have, how many do I have? There were 4 of us all together that did the ratings. We split it up so that I think I did all of them and I had 3 other people divide them up. So 2 people rated each recommendation. We did kind of some light inter-rater reliability sort of stuff. We worked together after looked at them, looked to see which ones were more disparate, talked through those more disparate ones. There were more instructions to it than I just presented. So we really did put some anchors more in there for, you know, what does a 2 look like? What does a 3 look like? What does a 4 look like? So that we were kind of all on the same page. So it was me, and I'm a doctoral level psychologist. There was another doctoral level psychologist, a social worker, and a nurse did the ratings. We were actually pretty concordant. So once we kind of got our information straight on, well, how do we really think of these things? Let me think what else. The nurse has a background, a lot of it in utilization management, which actually helps with that objective rating when it comes to her background. The other psychologist has been an executive in substance use treatment facilities in the community, as well as some state level work. I have, aside from the dissertation research stuff, experience more with state policy in those areas. And let's see, Selena, another person that has a lot of history in Medicaid policy and a lot of substance use policy knowledge. So we tried to keep it, like I said, as objective as we could. So it's a relative comparison between them.
Thank you for your question, Dr. Wagner, and thank you, Dr. Cantrell, for clarifying for us. I have another hand up. 1 second. Ariana, did you have your hand up?
Yeah.
There you are.
Yeah, hi, thanks. Similar to Dr. Wagner, I was just curious too if and what data sources were used to determine some of these rankings. I'm thinking specifically about impact and how you rate that, if there was any data or research that you used to help inform that.
So it had to be limited to what we know about Nevada and what's there. So, you know, prevention in schools is probably going to be not everybody, but most people. So impact wise, that's the number of lives. When it came to the magnitude to an individual person, we just did our best to judge, you know, relatively, is it saving a life? Is it just a slight increasing in some well-being? And then we had we talked through some points in between that we decided were likely impactful for those. That's why the recommendations are written at a certain level. We didn't want to get too detailed, but we had to get detailed enough that we know roughly what the target population is going to be and what the targeted impact was. Because of course, you know, the impact's not going to be the same for everybody, and it's going to vary according to the intensity of the intervention, but we tried to kind of go with what the intended impact and target population would have been.
Okay, thanks.
Mm-hmm.
All right, thank you, Ariana, for your question, and thank you, Dr. Cantrell, for responding. Do we have any more questions or concerns while we have Mercer here and have been given some information about their objective tool? Well, again, you know, if you feel that something's missing or that something doesn't belong, we want to know. I think moving forward, you know, what I'm a little bit confused on, Dr. Wagner, is at the bottom of the sheet that shows the ratings, we have ACRN recommendations and corresponding recommendations from the list above. And we have ACRN 1 through 18. And to the right of that on notes, we have the first, you know, if we take ACRN 1, the note is, this is a restatement of the legislative category. If you could just help me better understand how the approved recommendations by this committee are tied to the recommendations and categories up above. Oh, did I not say Dr. Cantrell? I'm sorry. I meant Dr. Cantrell. I'm not sure what I, sorry about that.
Okay.
I did. Sorry about that. How they're tied into what's above, I guess, is all I'm looking for. Just a little clarity.
Yeah, sure. So, you know, the ones that say, like the first one, the restatement of legislative category, that expanding access to evidence-based practices is actually the very first Johns Hopkins recommendation that's also in your legislation is expanding access to evidence-based prevention of substance use disorders, early intervention for persons at risk, da 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 da. So those are actually just a restatement of the legislative categories. So
Makes sense.
in that it was just a little too broad that we thought to have as a, we need specific recommendations for really what we do. So if you look at the file above, there are a whole bunch that under that legislative column in E do actually meet that treatment/early intervention and recovery support category. So it's almost like a categorical recommendation.
Okay, I see it.
Yeah. Were there more questions, or was that the main?
No, I guess, so it just takes a little bit of work to tie the note from the approved ACRN recommendation to the category up above in row E.
Yes.
Column.
So sorry, go ahead.
I was saying column E. Sorry.
Okay. Well, so ACRN 4, for instance, to sustainably invest in increasing utilization of secondary prevention, focus on targeting underserved populations as noted in the needs assessment. That is incredibly broad. So what we said was, if you look under column CDE, it says see secondary prevention categories, because we felt like if you pulled up all the things that are just in secondary prevention, there are a lot in there that are responsive to that type of recommendation that would fall into that broader category that are just more specific implementation for that. Does that make sense?
It does. And as I'm looking through, I am just looking for one that shows. Okay. Yeah, that totally makes sense. So it just takes a little brain work. That's all.
Yeah, if you sort by that category, then you should be able to see all the things that we think meet those requirements.
Okay. Thank you so much for the clarification. I was looking for the connection, but I couldn't find it, but now I totally see it.
Awesome.
And sorry for saying the wrong name. I apologize. All right. If we have no further questions or comments on agenda item number 4, I'd like to move forward to agenda item number 5. Oh, I have Dr. Kamyar. Your hand up.
Yeah, hey, Farzad Kamyar here. So just as, I guess, as a question or a summary, sounds like all this work was done, that individual members provided recommendations for homework at some point, maybe right now. We are going to each individually look at the summary of recommendations and see, hey, were recommendations that we made, did they fall into something that showed up? What does that ranking look like? Is there anything missing? We'll provide that as well, I guess, via email additionally. And then at some point, is the ACRN going to then decide, hey, of these 90 recommendations or 90 plus whatever was missing, et cetera, here's what we think should come through as the top whatever? Or do we have a goal here on like the number, limitations, anything like that? And I guess ultimately, is this something that'll be reviewed on a year-to-year basis moving forward to just, stay current with trends, current treatments, anything that's coming up, how things are working, how they're not working?
Yes, thank you so much, Dr. Kamyar. That's perfect. I'll ask Dr. Woodard to answer the second half of your question, but I'd like to clarify on the first half of your question, which is like a perfect setup moving into agenda items number 5 and 6. The plan from here is exactly that, to leave the committee with homework in which they will take the recommendations that we've heard and that we've seen as scored. And we'll take a week to review the recommendations and look at how they're ranked to make sure that our personal recommendations or what we feel as individual members needs to be included in our prioritization is somehow tied in to these 90 recommendations. And then what we're going to do is individually, I think that we should present our top 10 priorities for recommendation. I don't know that we should do that today. I think that we should do it as homework. And then from there, if we feel strongly about more than 10 of them, I'd like that to be included as well. And then we will either vote to approve the 10 prioritization, or we can go through them one by one. And we just need to make sure that if we feel that there's anything missing that we feel strongly about, to add that and include that. And we can talk about that now as we move into agenda item number 5 and 6. And then also, if we see any red flags, anything that doesn't look like it belongs or that is an issue, we also want to know about that and talk about that. Dr. Woodard, can you clarify a little further for me, please?
Sure. So Stephanie Woodard for the record. I wanted to just comment on the question that Dr. Kamiar asked around how frequently we can do this. So legislatively, we are required to update the needs assessment every 3 years, but we are not limited to updating it more frequently than that. Certainly, I would hesitate updating it any more than annually. But we felt that 3 years was sufficient time for us to be able to demonstrate progress towards some of the activities and to be able to update as relevant information becomes available. I think that as you read through the recommendations, you will see that many of them we anticipate will be relevant and pertinent going through the next 3 years. But if there is something that is, a pretty significant shift in what we're seeing in Nevada, there's nothing that prohibits this group from coming back together. If there is, for some reason, a need to bring forward a new and different recommendation or amplify something that is a recommendation that maybe has not ranked as high in priority. So we're not limited to that 3 years.
Thank you, Dr. Woodard. Carissa, your hand is up.
Yeah, thank you, Chair. I just wanted, this is Carissa Loper for the record. I wanted to clarify on the top 10 conversation or instructions. I may have missed something you said. Are we going to come up with the top 10, each of us, in homework, or is that what we're about to discuss in agenda items 5 and 6?
I think we have the option for either, but I feel like the committee should decide together whether or not we want to do that today and go through them, or if we want to take that as something that we do over the next week and then come back with what the 10 that we have chosen. And just to clarify, we don't need to be limited to 10. It's just that's what we've kind of been rolling with throughout our time together, is that we'll prioritize 10 recommendations, but really, if we're not, we don't have to leave anything out. We can put as much as we feel strongly about as we move forward, and we can go as far as to agree and approve them all as recommendations if that's what happens, and put that in our report to the director's office. But I think we initially started with this conversation about coming up with at least 10, and I think because we had some difficulties moving forward in our first couple of months of meeting, that it seemed feasible that 10 would be okay. But now that we have what we have, and we're all getting a little bit of clarification on what our recommendations are going to do and what they're looking like, whatever the group feels, we can move through them 10 at a time and say, no to 3 and yes to 7, or whatever that may look like. But I guess at the end of the day, what we agree upon as our prioritized recommendations, we can, that will be included in our report to the director's office. And just so that I'm on the right step, I want to just confirm that we are, that we're going to actually leave agenda item, and I see your hands up, Cornelius and Dr. Wagner. We're going to leave agenda item number 4, and we're going to move into agenda item number 5, because it seems like we're moving that direction. And this is again for possible action. And you know what, I'm going to merge agenda item number 5 and agenda item number 6 together, and we'll call it possible action for discussion and possible approval of ACR recommendations concerning the allocation and distribution of money from the Fund for Resilient Nevada. And so now this is where we're talking about, do we want to another week to review the recommendations and how they're ranked? Do we want to move them all forward as they're ranked? Is there anything missing that we feel strongly about? Do we want to move these forward into the report as is, or do we need to prioritize them based off of what we feel is important as a group? And sorry for interrupting, but I just want to clarify where we're at as far as the open meeting is concerned. Cornelius, you have the floor.
Oh, thank you, Mr. Chair. I appreciate your clarification on the 10, the number, moving forward with 10. I wasn't sure it would be wise to set an arbitrary limit on, given what we're dealing with, the topic matter. So thank you for clarifying.
Yes, sir. I have Dr. Wagner.
Hi, thanks, Carla Wagner. I have a comment and a question.
Please.
I feel like there's so many things in here. I need a little time to look at it. I don't feel like these are decisions that I'm prepared to make right in this moment. The question is related to that. Dr. Cantrell, do you guys have do you have locks on some of the fields? I'm having trouble navigating through the spreadsheet in certain ways. Do you have some stuff in here locked down? Or is it my computer that's acting buggy?
Dr. Cantrell,
They're all protected.
Okay.
Sorry, no, you're
Go
good,
ahead,
Dr.
I'm so sorry.
I'm sorry for interrupting you, but I just wanted to jump in for a second and say that Dr. Wagner, we received 2 of the same file. One is the one that is rated and is final to us. And then we have a second one that has no ratings, and that one is editable.
Okay, so I'm navigating in the final one that has the ratings. I'm sorting and filtering, etc. And as I'm moving in some fields, it's just not behaving like I would expect. So that is because you have some things locked down.
That's you, Dr. Cantrell.
Yes, thank you. This is Courtney Cantrell. For the integrity of something so big that we were sending out to everybody, yes, the cells content-wise are locked down. But let me know if you have some other effects, like you can't sort or something other strange thing is happening.
Well, the thing that I was having trouble with is as I'm trying to make things bigger so that I can see it, sometimes I feel like I'm not seeing the full text in a field. And so I was trying to click on the field with in column B to like see all the text as I was kind of making things bigger and smaller so I could see them. But maybe that is a really minor thing. And now that I understand what we're working with, I can work around it.
This is far as on camera.
Yeah, so I will say that if you go ahead, I'm sorry.
I was as far as I can hear again. The biggest issue I was having was that the final document is not searchable. Like I can't do a control find on it and plug in keywords to find, hey, this is the one that mentions Matt, this is the one that mentions Esper, et cetera, et cetera. So what I'm doing is I'm having to go to the original do the find, figure out which number that is, then go to the rating document.
So
this is Carissa.
Carissa.
I just to his comment. I'm sorry, I can't. Your full name, Farad. But I saved it as in my computer, and it's still locked, but I did Control F and it worked. So maybe you're in the read-only version and you need to save a version on your own computer. Administrative comment.
Awesome, though. That's super helpful. I think it's going to be a mix of one of two things. Either as a committee, we're going to use the document with no ratings to kind of use that as an editable and searchable document, and then we'll look back at the final and we'll see our ratings there, or we're going to ask that somehow administratively we're able to access and get involved with the final version. Does anybody have any suggestions or comments about what we're going to do as the committee takes these two documents and works on them as part of homework over the next week?
This is Carissa Loper for the record. So I'll just say, maybe I'll give my understanding and you chair, Dr. Woodard, someone can confirm. So what I'm doing right now is kind of writing notes within the notes field that we can work in the locked rated document. Based on what I'm seeing, what I'm reading about the recommendation and the scoring based on their scoring impact thing. And then those notes, is that what we'll send to Joan and Dawn as our assignment, if you will? Is that the understanding for others?
Yeah, that's really a good question. And if I can get either Dawn or Dr. Woodard to help clarify what it is going to look like for the individual committee members to, as they go over this the next week, how they present what it is they're bringing back.
This is Dawn. I think what would be best is for you to bring your notes back with you to the next meeting and to have discussion. I don't think it would be helpful for Joan or I to gather all of the notes together, but if you have, your top however many, or if you just have notes on all of them, I think it's easier for you to come back for discussion with your own notes.
Does that make sense to the committee members? Do you feel comfortable with that? Does that make sense to you? Is that clarifying and kind of guiding what we're going to do in between now and our next meeting? Don, one more time.
One more, this is Dawn. One more thing, if you are not going to be at the next meeting and you want your notes to be read, please do send them to us, and then we will keep track of those ones if you're not going to be here next week, and then we can walk through those ones with the chair so that they are also heard.
Thank you, Dawn. This is Carissa Loper for the record. That helps for me because I will be out for the next meeting. Thank you.
For us on camera here, would that include bringing to the next meeting recommendations that we feel are missing?
Yes, absolutely.
Correct. Mm-hmm. And we actually do have some of the recommendations that you guys had sent to us, and we mapped those to the recommendations that Mercer had done. And so we have notes on those that we can share with you guys if you want to see that. Or I can send you the ones that you did, Dr. Kamiar, back to you later.
Does anybody else have any comments or questions? Are we starting to get a little bit of clarification as far as what it looks like between today's meeting and our next meeting? I have a question. What does it look like when? So again, we have ACRN 1 through 18 at the bottom of the final recommendations page by Mercer. But as you just said, specifically with Dr. Kamiar's recommendations or something that is missing, are we going, how, I guess at the next meeting, we'll include those additional recommendations that are not seen on this list, and then we will list them as ACRN 19 through whatever, and then we'll tie them into the existing recommendations that are above, or what does that look like? I'm sorry. I don't know if I'm totally.
This is Dawn. I think that's a great question, but like Dr. Woodard mentioned earlier, there are a couple of recommendations that we noticed were missing that we'll have to go through the objective tool. But if there are recommendations that we're not able to map directly to the recommendations that have already been ranked, we're going to have to go back to see if it's something that we need to go ahead and put in and rank it through the objective tool.
Okay. So from here, being that we're on agenda item number 5 and 6 combined, we are not currently going to approve any of our prioritized recommendations, but we are going to take these 2 documents with us over the next week. We're going to go through them we're going to add our notes and kind of get an idea of what is important to each one of us. We'll review the spreadsheet, identify the recommendations that each one of us would like personally to move forward, all of them or some of them. If you don't want to leave any out and you're comfortable with all of them, then we can just simply, all of them are good individually. Or if you want to, highlight ones that you're not comfortable with or that you don't want to move forward. And then we'll use what we each bring back individually to kind of make that approval or vote on for our committee's recommendations that will go into our report to the director. And at that point, we'll add or identify and add any recommendations that are missing, and then we'll take a vote and start moving things forward. Does that make sense to everyone? And does that sound right to Dawn and Dr. Woodard? Dr. Wagner, I have your hand up.
Hi, thanks, Carla Wagner. I just wanted to add one clarifying point to make sure I'm real clear on the charge.
Yeah.
Because I'm sure as I look at all of these things, I'm going to think that all of these 92 things are probably good things and we should probably do them all. But our report is specifically to make recommendations concerning the allocation and distribution of money from the Fund for a Resilient Nevada, right? So we are not, I just want to clarify I am not making recommendations about how we think we're going to solve the overdose crisis in Nevada. I am making recommendations about how we think we should allocate these funds that came from this particular settlement to remediate the harms. Is that right?
Yes, that's my understanding. That's exactly it. That's right.
Because these funds are available as part of a settlement that was specifically designed or specifically settled to remediate harms.
Yes.
Right. That was a condition of the settlement was that we are using these funds to address the harms that were created.
I believe so. Dr. Woodard?
Harms, risks, and impacts. So all three.
Okay. I'm just writing this down on my notes so that as I think about, like, every time we recommend that this action be taken to remediate the harms, risks, and blah, blah, blah. It'll help me stay focused.
Mm-hmm.
Thank you.
No, totally. Yes, that keeping that at the top as I go through them definitely clarifies things for me. Dr. Ariana.
Yeah, I was also wondering as we're going through this through our homework, I noticed that there are some legislative categories that aren't covered in here. Is that something that we should be concerned about or focused on? I don't know, Dr. Woodard, if you can say, like, do we need to make sure we have a recommendation that falls under each of these legislative categories? No, okay.
Dr. Cameo? I'm sorry, I just want to make sure. Ariana, that clarifies it for you, right? You're good? Okay. Dr. Cameo?
Sorry, Chair, if I may, because I noticed I just gave a nod. So Stephanie Woodard for the record. So we are not limited to the areas that are in the legislation. So it is a suggested list, but it's not a limiting list. And we don't have to necessarily have recommendations under each of those categories.
That makes sense and clarifies. Thank you. Dr. Camera, did you still? Thank you.
Yeah, as far as on camera. So, okay. So then next time we're coming forward with, here's our prioritized list. Here's maybe recommendations that we made that don't fit in. Here's ones that we think are missing. And then at that meeting, are those then going to have to go through the stratification tool? And so in subsequent meetings, we will evaluate those to potentially be added to the list, prioritized.
That is a good question. I know that anything new that we add or that's missing and we feel strongly about and we need to add it as a new and included recommendation, I believe that will have to go through the objective tool. but I'm not sure what that looks like as it goes into the report, because I know that we're moving towards a completion of the report in the next 2 meetings. Does anybody, Don?
Don Yohey for the record. I think hopefully this can help you. If you have really strong suggestions, we can add it to the report and we can rank it afterwards, but we can always add it to the report as a suggestion from the ACRN. You don't have to follow the ranking as, you know, priority. So we can always add it if it's something this team feels really strongly about.
Okay. Dr. Wagner? Wait, before Dr. Wagner, Dr. Cameo, does that make sense?
Yeah, potentially. Yeah, I guess just fundamentally, I would want recommendations that are made to be fully evaluated. You know, like, for example, I'll just give you an example. A big one that I'm seeing is missing is a couple of things about like offices and positions created. But one that's sort of legislatively is the whole evaluate existing programs. I don't see a lot about that. And I feel really strongly about that when it comes to addiction treatment or substance use treatment quality. So I would feel that's really important, but I would want that to be considered and ranked and sort of justified and agreed upon versus just stuck into, right, something that might not get weighted a lot.
Yeah, I understand what you're saying, and it is, I think my big challenge is trying to identify, like, specifically the evaluation of providers, like you just spoke on. How do I see that inside of there? And as I look through, I can possibly tie it to one, but how do we ensure that it is included? And then what does it look like after it goes through the objective tool? I'm kind of with you on that, but I think we're almost there as far as like understanding clarification and what it's going to look like as we approve. Dr. Wagner, I see your hand up, but I'd like to call Dr. Cantrell before you speak. Thank you.
I just wanted to mention in thinking through that, there are so many things that can be evaluated and should be evaluated that what I ended up doing in the report is saying at the beginning of the recommendations that whether it's evidence-based or something that we're not sure, you know, and needs monitoring, everything should be evaluated for outcomes and measured very closely. So whatever's implemented should be looked at, because we found it really hard to have such a broad recommendation that everything needs to be evaluated. That's really hard to put a monetary value to. It's hard to put, you know, we don't know the population of what, you know, if you started tomorrow, let's do that, then what would the next step be is kind of a very difficult one. So I would recommend that as you're forming those recommendations, being very specific about which things you want measured and what that might look like. But that was just from our experience and we're working through that a little bit.
Awesome response. Thank you very much, Dr. Cantrell. And I see Dr. Woodard, and hopefully we're on the same line of thought here. Please, Dr. Woodard.
So Stephanie Woodard for the record. Thank you, Chair. One other recommendation that could be made is not necessarily around, you know, specific recommendations for allocation of funding, but if you see that there is a general theme or tie that you want to make sure is put into the report for your recommendations, you could, as a committee, determine that that is something, program evaluation is something that is just overarching that you want to make sure is really anchored to all of the recommendations that you're moving forward with. That way you don't necessarily have to get into sort of the granular specificity of what you would want measured for each of the activities that you're recommending. To me, I think that that is an option for the committee to potentially consider.
So does that look like a pre-statement? Here are our recommendations, and as these are considered by the director's office, we would like them to be considered with a lens of every or all of our recommendations include program evaluation to confirm that X, Y, and Z is is being affected or happening.
Stephanie Woodard for the record, yes.
Dr. Kamiar, how does that sit? And committee, what do you think of what we just went over? Does that make sense? Does it answer the need? Does it meet what we would like to see happen? Do we have any questions or comments or clarifications needed? I think that gave me a big piece forward as far as efficiency and how it's going to look in action. Okay. I had something else oh, Dr. Wagner, there it is. You had your hand up. Thank you.
Thank you, Carla Wagner. I just wanted to express my thanks to the state team and the Mercer team for doing this work. I really felt like these past few meetings like I was filling and didn't know what to do or what my role was, but I feel like I can sink my teeth into this in a meaningful way now. So I just wanted to acknowledge all the hard work that went into that on behalf of the folks at Mercer and the state.
Absolutely. Thank you so much, Dr. Wagner, for saying that. Yes, the both teams are like instrumental in helping us get where we're at and hopefully finishing what we're going to be. And, you know, I just, during that same line of thought, I just like to say as the chair, I wish I could have done a little bit better at guiding you guys and making some things happen by putting some force on getting us moving forward in the early months. But regardless, we're all doing the best we can. And I think as long as we show up and suit up and give our 2 cents and you know, bring our expertise to the table, it's going to be meaningful at the end of the day. So Dr. Kamiar, I have your hand up.
On here, Dr. Woodard and the team, I may have missed this, but do we have like do we make recommendations from a planning perspective on, you know, there's funds coming in, who knows when they're coming in, but we have a certain chunk now, they should be allocated and used XYZ on an annual basis, on a 5-year basis, 10-year basis. Is there anything along those lines?
So Stephanie Woodard for the record, sorry, Chair, if I may.
Please.
It's a great question, and the legislation is not specific. So really the recommendations that are coming out of this committee are generated from this committee. So however you would like to frame your recommendations, this committee is free to do so. There are no limitations put on this committee for the recommendations that you'd like to be able to carry forward. With that though, I would also just want to, I don't know if it was mentioned as we were getting on, but the SURGE, which is the Attorney General Substance Use Working Group, met yesterday. And there was a very detailed presentation by the Attorney General's office to explain the allocation of funds and where those dollars are going. So I would really recommend, and certainly we can have staff send out the link for the recording of the meeting and the materials from yesterday. Would really recommend this group familiarize yourself with that information. It's information that he has presented to this group in the past, but they've gone the extra step to look and determine what the specific allocations will be that are coming to the Fund for Resilient Nevada. And then the Attorney General's office is also breaking that down by county. So just as a reminder, the state's allocation is only a portion of the funding that is coming into the state. The cities and counties that have also participated in the litigation are also getting their allocations. So the Fund for Resilient Nevada is really only the dollars that are coming to DHHS to be distributed for statewide specific initiatives. This is not granular down to the county. That's why the counties are receiving their own allocations. So just wanted to kind of reiterate that because there was a couple of aha moments yesterday in the SURGE meeting that I thought that information would be valuable to this committee. So in looking at it, to Dr. Kamiar, to your point, a rough estimation, because I'm just doing this off the top of my head, I don't have the materials in front of me, but we should by July have in the Fund for Resilient Nevada approximately $44 million. And that is the largest allocation that we will be receiving unless there is another settlement that will also provide a large allocation of funds. So $44 million to people may sound like a lot of money, but then we are only receiving allocations between, I believe, 2 and 4 million annually for the next 15, 16 years. And so we really need to make sure that we're mindful of how we are utilizing those dollars, because certainly $44 million could go very quickly in a year. But we don't want to start programs that we won't be able to sustain over the long term. So just another little caveat that I wanted to put out there.
Great, thank you, Dr. Woodard. Dr. Camera, does that answer your question?
Yeah, for us out here, yes, of course. Yes, thank you.
Thank you. I have Cornelius, you have your hand up?
I do. Thank you, Mr. Chair. Cornelius Sheehan. I think it's important that we remember the fact that we're all coming with different areas of expertise on the ground, and in consideration of all these factors, I'm looking at a number of them that I can't speak to. They're wonderful, and I get them as concepts. I'm familiar with them professionally, but I haven't worked with them operationally, and so I'll be relying on other committee members to contextualize those items for me. And originally we started with this diverse expertise, and I'm hoping the committee will maintain that spirit as we finalize recommendations.
Absolutely. Thank you so much, Cornelius. You know, and I think that that brings up a good point. When I look at it, I can get overwhelmed, but I don't have to be. I can stick to what I know and what is important to me. And I also, while I was thinking of that, I was thinking that, you know, I use my expertise to bring to the table what is important as I do my homework and I bring this information back to the next meeting. But that doesn't necessarily mean that I just cut off all the rest that I don't know about or that are not important to me. And I want to leave it open and just as an awareness that we can move forward with these recommendations as a whole, all 92 of them, add what we see that is missing and have that in our report. So our report will be this big, thorough thing, but we can specify this is what was important to the committee and prioritize them from top to bottom. And you know, maybe out of the 15 of us, we don't touch on 30 of them. Nobody says anything about 30 of them. That's fine. Then we'll just leave those at the bottom and we'll prioritize the ones that we did have some say about or that did speak to our expertise and are important to us up at the top. Does that make sense? And can I get a, that sounds good from one of the Dr. Woodard or Dawn or Dr. Cantrell? Is that sounds right, right? I think that sounds right. I'm just looking at smiling faces, so I'm just going to say that sounds right. Okay, so, and yes, thank you so much, Cornelius, for saying that. So there is a lot of work to do, and I do appreciate the each individual that brings their expertise. There's going to be some of us that know a little bit more about what these recommendations look like in action compared to myself. I might not be as enmeshed or involved with some of the recommendations and not be entirely clear on what they mean. But what my job is and my responsibility as an individual committee member is to go over them and add anything that I'm not seeing that is important. And then add notes and prioritize so that when we meet next time, we can go over these recommendations and group them and vote on them to be approved and included in our report. Does everybody seem to be on the same page, and are we all clear on what our responsibilities and roles are after we leave this meeting and leading up to our next meeting?
Yes.
Now is the time to throw any questions out there or comments or clarifications. Okay. That's really awesome. I think that this has been a really productive meeting, and although we didn't start doing any voting, I want us to be really ready and prepared next meeting to be able to work together, and I'll bring up each recommendation and then I will say, okay, actually, I think we'll group recommendations so we don't have to do 90 different votes. And we'll group recommendations and say, I don't know how we're going to do it, but something about prioritizing them as a group and then grouping them for approval for voting. And then we'll move them into our report. At that time, I believe that Dawn will be giving us a update on what it looks like for our final report. And I think it should be just about good to go, besides adding in our approved upon and voted on prioritization of recommendations that will be needed to be added to her report. I think we are ready to move forward from agenda items combined number 5 and 6 into agenda item. Let me just check my participant list. We can move forward to agenda item number 7. Dawn, did we want to skip the update of this report and move to it next meeting, or did you want to speak on it today?
This is Dawn. No, we can go ahead and skip it and move on, move it to next week, because I think everybody has a lot of information in their head right now and has a good charge, and I don't want to jump in and start muddying that up for you.
Yes, thank you so much. That makes really, really good sense. And I can't believe it. I feel like we're all on a really clear, purposeful path right now. And now we just start notching through our final recommendations from Mercer. And I guess I know for me personally, I'll probably have some technical difficulties with adding and making notes and, moving things up and down, but I'm just gonna copy and paste if I have to, or edit a different saved version to my computer and then bring back that document so we can go through it next week. I guess then at this point, we will move forward from agenda item number 7, and we will move on to agenda item number 8, which is public comment number 2. Again, we will take public comment at this time. Please avoid repetition and limit your comments to no more than 3 minutes, and be aware that no action may be taken on the matter discussed under this item. I have one hand raised for public comment, and then I believe I have an email that needs to be added to public comment. I lost the person. Did we add them? Okay. I have Terry Kerns for public comment.
Thank you,
Okay.
Chair. This is Terry Kerns from the Attorney General's office. And I just wanted to provide the comment that I know Dr. Woodard made reference to some materials that were presented yesterday at the statewide substance use response working group meeting. And there was also an answer to the public comment question about distribution of funds to those who have individually suffered damages. So what I am going to do is, as soon as the recording of that surge meeting is available, I will pass that on to Dawn Yohey, who can then get that out to whomever is interested in listening to it. Thank you.
Thank you for your comment. And we will be looking forward to getting the information from the surge meeting. That's something that I think is going to be super important for us to pay attention to as individual members, and as we're considering what our prioritization of our recommendations looks like over the next week. So hopefully we can get that as soon as it's ready. At this point, I still have public comment number 2 open, but I do not see anybody available or interested in speaking for public comment number 2. However, we did receive an email regarding public comment from a person or agency in the community, and I am looking to the state team now to make sure that we have that covered for this portion of public comment. Dawn or Joan. Do we know what we're going to do with that email that we received with the letter that was asked to be part of public comment? I'll give you both a minute to consider that, and I'm going to call on Cornelius to jump in real quick.
Thank you, Mr. Chair. If it's appropriate at some point before we close today, there was a media item that came up very relevant to Matt, to stigma, and I just wanted to take a moment, if it's appropriate, to direct committee members to that for their own review to see that. So please advise me if it's appropriate to introduce that information. And if not, I can do it under separate cover, but I think it was really relevant to what we're doing. And
okay. One second, Cornelius, let me confirm
Sure.
with the team that this is okay for you to, is it okay if Cornelius brings forward his information that was recently released? Or yes, it is. I think it is okay. So go ahead, Cornelius, and then after that, I will be reading the public comment letter that we received between last meeting and today's meeting. So Cornelius, if you
okay, Mr. Chair and committee, would you like me to wait until I'd like to honor the public comment space first before I insert? Would that?
Yeah, but I think,
preference?
yeah, that's fine, Cornelius. I'll read the letter, and then after that, if you want to speak, as I believe as part of public comment, but I'm not exactly sure. But I will read this letter, and then I'll get clarification while I'm doing that to make sure that we're on. Yes, so you will be speaking as part of public comment, Cornelius, so it'll be no problem. But I will read the letter that we received from Acadia Healthcare. Public comment for Advisory Committee for Resilient Nevada. Good morning, members of the Advisory Committee for Resilient Nevada. My name is Aaron McCarthy, Regional Vice President with Acadia Healthcare, and I oversee operations for our 2 Nevada opioid treatment programs in Clark County. I've been working in the OTP modality for the last 15 years in a variety of direct care and leadership roles, and I've seen firsthand the, I looked away and lost my place. I've seen efficacy of OTP services in providing patients the tools and resources to change their lives. These locations were purchased by Acadia Healthcare in 2019, but have been in operation as mission treatment centers for over 2 decades. We provide medication-assisted treatment to approximately 1,000 individuals with opioid use disorder between our 2 locations. We currently employ about 30 plus individuals who provide medication and counseling services to those 1,000 patients. Our employees consist of certified and licensed alcohol and drug counselors, nurses, physicians, mid-level providers, and administrative support staff. From 2020 to 2021, both our locations saw a 30% higher increase in all staff turnover, with an average of 40% of all new hires leaving before 1 year of employment. Specifically significant is the growing challenges to hire and retain certified or licensed alcohol and drug counselors. Both locations experienced almost 100% turnover of counselor positions. The counselor role is one of the most critical within the OTP setting and a significant factor in the patient's experience and progress towards their recovery goals. In the 2018 article, Facing Addiction in America, the Surgeon General's Spotlight on Opioids, Dr. Eleanor McCants, the now former Assistant Secretary for Mental Health and Substance Use, commented, medication-assisted treatment combined with psychosocial therapies and community-based recovery supports is the gold standard for treating opioid addiction. In addition to our programs providing medications and counseling services, both are certified co-occurring disorder providers. Both provide specialized services to pregnant and parenting women, and both have well-established partnerships with other community providers and resources. It is our hope that in your review and determination of how opioid settlement funds should be used, that you will take into consideration the ongoing workforce constraints specifically related to OTPs and will appropriate specific provider financial support for these issues. In several other states where Acadia operates OTPs, we have already seen workforce financial support through the use of ARPA funds and SAMHSA grants, and we are optimistic and advocating for portions of the opioid settlement funds to also be designed as such. This support has varied from temporary increased fee-for-service reimbursement rates, loan forgiveness programs, and lump sums for use in employee sign-on and retention bonuses, etc. While we acknowledge that the financial support might not solve the overall workforce problems today, it certainly provides aid to ensure OTPs remain sufficiently staffed to provide quality services and improved patient outcomes. Is that 3 minutes? It's got to be 3 minutes, right? No, yes, no, no, yes, no. All right, I'm going to finish then. In closing, we want to thank you for your work and dedication on this topic. I'm sure we all share the same common goals to reduce opioid overdose related deaths in Nevada and improve the lives of Nevada's struggling with opioid use disorder by ensuring continued access to life-saving medication and counseling. One way to ensure access to care is to support the stability of existing OTP providers who are being stretched thin because of unprecedented behavioral health staffing shortages. This letter will be included with the minutes, and thank you for bearing with me while I shared that public comment. I'd now like to move to Cornelius for his public comment in regards to, did you say peer staff? What? Please, Cornelius.
It was a media item. Thank you, Mr. Chair. Cornelius Sheehan for the record. To direct the committee to, if you have access to it, have a look at the most recent airing of Bill Maher's show Real Time on HBO, and so there's a segment in the program. It was kind of a knockout. I couldn't believe it was happening, but there's a panel discussion, and they're mocking a couple of public announcement flyers. Maybe some people saw that. It had to do with harm reduction, had to do with stigma, and I actually, from that source, was surprised to see it because I'm familiar with the source and didn't think the commentary would go the way it did. But pardon me, committee. The flyers were from San Francisco City and New York City, and had to do with harm reduction, needle exchange programs. And there was a complete misunderstanding of the material the way we would understand it, those of us that work in the field. And there was a lot of audience buy-in to the mocking of those harm reduction program announcements. And so I think what was interesting to me as far as the committee goes, it's illustrative of some of the work we have to do in terms of education around the stigma on these things. Their essential point was, it's like, people can get better. Why encourage them more to be addicts or to use, when instead the resource should go into getting them better? And of course, they're missing some key points. And one is, if you keep them alive, you have an opportunity to get them better. If you don't, that window closes. And so something obvious like that wasn't seen, but I was really, really surprised at the direction. So if that interests people, I just wanted to let the committee know. Thank you, Mr. Chair.
Thank you, Cornelius. Thank you for sharing that with us. And I can say, as far as the general population goes, I think there's a lot of education that needs to be done, or that would be helpful if it were somehow around and available for people to get a better understanding of what harm reduction specifically looks like, but also what the damage of stigma looks like. But that being said, I believe there's people that are, that have the same intentions as we do, and as we bring to this committee, that still have misconceptions about what harm reduction looks like and what it is meant to do. And I was waiting for it, but thankfully Dr. Wagner put up her hand to speak further on this. But yes, I would say, as much as there's a portion of the very field that aims to serve the people that we're looking to help, still have confusion and could use education, and are conflicted on the viability of harm reduction. So there's definitely work to be done. Dr. Wagner?
Hi, thanks, Carla Wagner. Just because we're talking about this, I wanted to make the committee and anybody in the audience aware that the state's ODTA, Office of Overdose Data to Action, the CDC-funded ODTA grant, is sponsoring a 2-day harm reduction summit for Nevada, 1 day in the north and 1 day in the south in July. I think the dates are July 19th and 20th. And I think save the date announcements are starting to go out, but people should be aware there's going to be 2 full days, and it has sort of an educational mission in terms of familiarizing people with the spirit of harm reduction, but then also there's kind of going to be 2 tracks, I think, one that's more educational and one that's more kind of forward thinking and developmental for practitioners. So this is being sponsored by the CDC grant. Information will be coming out, but people should be aware of it.
Thank you so much, Dr. Wagner, and absolutely people should be aware of it. I think that that's a hope of mine, at least with this committee, is that somehow in some way down the line, there's a seed planted that we were a part of that helps someone develop something that would have been not even considered, years ago, and that is now should be, and it is starting to be generally accepted as this is the way that we should be going with this. Let's keep people alive. Let's find a way that might not be common today, but that will have beneficial effects in the future. And that's like my idea or my beliefs around harm reduction is that I don't think it was always accepted, and even today it's not accepted, but I think we're seeing big gains and a usefulness out of it that is parallel to the gold standard. So thank you for sharing, both of you. Dr. Wagner?
Is it okay if this is Carla Wagner, is it okay if I send the save the date or the flyer information to Joan and the team and they can add it to the, something that
absolutely.
can be in the meeting minutes?
Absolutely.
Okay.
Thank you. All right. Let me just double check. Did we get anybody else with a hand up in the public comment section while I was reading the letter, or we had Cornelius or myself speaking? Joan, did you see him? Okay. That will be the end of public comment number 2 and agenda item number 8, and we will move on to agenda item number 9. Which is the notice of the date of the next ACRN meeting to be held on June 15th, 1 week from today. Again, if you're able, please block 3 hours. We will be meeting from 9 to 12. I understand that there's some people who have given notice that they either will not be able to attend or that they will have to leave early. At this next meeting, we will be planning on doing a pretty heavy load of voting and approving, and we'll also be given a presentation of what our report going to the director's office is going to look like. Thank you everyone for being here and participating, and I appreciate your support and your commitment to this committee. Looks like the invite for next week is only 2 hours, so be ready to get some things done and to have some, oh, nice, it can be changed. Okay, so it's gonna be 3 hours. We're good, Sorry about that. At this point, I'd like to adjourn this meeting. Thank you very much for being with us today, and we'll see you next week. Good luck with your homework. Thank you.